Title: Improving Nonsurgical Management of Urinary Incontinence in Women. Friday, October 14, 2022, 2:30 p.m. to 4 p.m. Eastern Time, 11:30 a.m. to 1 p.m. Pacific Time. EvidenceNOW logo. Managing Urinary Incontinence in AHRQ Initiative. AHRQ logo. Agency for Healthcare Research and Quality. Department of Health and Human Services, USA. Live video feed overlay of speaker Elizabeth Cope.
All right, welcome everyone to our public webinar focused on improving non-surgical management of urinary incontinence in women. So I want to thank everyone for joining us today, and it is my pleasure to welcome you all to this presentation where we'll be talking about AHRQ's newest addition to the EvidenceNOW family, which is focused on managing urinary incontinence in women. Next slide, please.
Webinar agenda. Welcome. The challenge and opportunity. Patient and provider perspectives. Introduction to EvidenceNOW. Managing Urinary Incontinence, MUI. Grantee project overviews. Q&A closing. Great.
So I want to just share a little bit about what we're going to be talking about today. First, I will turn things over to Arlene Bierman from AHRQ to welcome you all. Then we're going to hear a bit about the EvidenceNOW family and how this new project and new initiative fits into that portfolio. And then we will have some discussion with both a patient and a provider to hear their perspectives on the challenges that exist related to this condition and the improvements that we can make and the kind of impact that an initiative like this can have. And then we'll hear a bit more from each of the different 5 grantee teams to talk about each of their projects as well. So a little bit of housekeeping, and I should say, sorry, that once we wrap the presentation, so we're going to go through each of the grantee presentations. There will be 5 of them, and then we will have time for Q&A. So be thinking of whatever questions you might have and save those up and share those with us, and we can make sure that those get shared with the panelists during our Q&A time. So just a little bit of housekeeping before we jump in. This meeting is being recorded. All meeting materials will be uploaded to AHRQ's Managing Urinary Incontinence webpage. There will be a designated time, as I mentioned, for questions. So if you submit those questions using the Q&A function specifically in Zoom, that is how you will get those questions to us. At the end of the webinar, also, this is very important for us, you'll be prompted to complete a survey in your browser. This helps us know how we can do a better job on these kinds of events going forward. So we'd really appreciate your feedback. If you're unable to do it at the end of the webinar, we will also be providing you a link to this survey in a follow-up email following the webinar. So first, I would like to turn things over to Dr. Arlene Bierman, who is Director of AHRQ's Center for Evidence and Practice Improvement, who will talk a little bit about AHRQ's mission and how this work fits in.
Title: Welcome. Arlene Bierman, MD, MSAHRQ, Center for Evidence and Practice Improvement. Live video feed overlay of speaker Arlene Bierman.
Oh, hi, it's great to be here today. Thank you all for joining us. We're all very excited about AHRQ's initiative on managing urinary incontinence and all of the work that the grantees you're going to hear from today are doing. Next slide. You could go to the next slide. So just, to let you know, the Agency for Healthcare Research and Quality's mission is to produce evidence to make healthcare safer, higher quality, more accessible, equitable, and affordable, and to work with the Department of Health and Human Services and other partners to make sure that the evidence is understood and used, and that really benefits people to improve their health and well-being.
Link: www.ahrq.gov.
Next slide.
Title: Leveraging the knowledge to practice to data cycle to strengthen the value of patient care. Graphic, 3 circles, 2 on top and 1 on bottom between them. Between the circles are arrows indicating a repeating cycle going from left to right to bottom and back up, with another circle in the open space in the middle of them. The top left circle is dark orange and contains a black graphic of a light bulb. Beneath it is the word knowledge, and beneath that it says systematically identifying and synthesizing evidence to address clinical challenges, e.g. systematic evidence reviews, clinical practice guidelines. The top right circle is teal with a black graphic of 2 people at a table chatting, one of which wears a stethoscope. Beneath the circle is the word practice, and below that it says applying knowledge to practice in the process of care delivery, e.g. clinical decision support, clinical pathways. The bottom circle is dark yellow with a black graphic of a bar graph with an arrow on top, showing the trend and pointing upward. Beneath the circle is the word data, and below that it says continuously assessing performance and creating a feedback cycle for learning and improvement, e.g. patient registries, electronic health records. In the middle of the graphic is a light blue circle with a black graphic of 5 faceless people shapes. Image credit: Borsky A., Flores E., Berliner E., Chang C., Umschied, California, Chang S. Journal of Hospital Medicine, 2019, 14.5 311-314.
So, many of you know about the learning health system model, and this is a model that we use for our EvidenceNOW initiatives, so that, there's evidence, there's the knowledge, and we know we have a lot of, Dr. Hooper is going to give you a lot more background on the history of this project and what we're doing, but we know that there's a lot of strong evidence on both behavioral and pharmacologic interventions for urinary incontinence. We know that it's a common problem, a big impact on quality of life. We know that it's underdiagnosed and undermanaged. And so we want to take that knowledge. We're tasked also under the Affordable Care Act to implement patient-centered outcomes research into practice. So taking that evidence and getting into practice, but then there's a whole science about how do we implement it in effective ways. And I think that's what you're going to hear today. And then that practice, we generate practice-based evidence. We learn both about what works in different populations, as well as which strategies work to improve care. So we generate data, which then again improves our knowledge base. Next slide. So the approach we are taking with our EvidenceNOW and our implementation, dissemination and implementation portfolio is really to learn while we're implementing, so that we're integrating quality improvement and implementation science. And so the EvidenceNOW suite of initiatives really is an approach for delivering external support to primary care practices to improve healthcare quality and implement new evidence into care delivery. And so a lot of our prior initiatives are actually informing this one, as we've learned a lot about implementing evidence and building capacity for quality improvement in primary care. Our Advancing Heart Health initiative really talked about how to develop quality improvement capacity in small and medium-sized practices. We have another initiative on advancing equity in heart health by building the capacity of states, both to improve care as well as to address equity issues. And that one is tackling hypertension control and smoking cessation. We have another initiative on managing unhealthy alcohol use in primary care, which is really teaching us how to integrate behavioral health in primary care. And this one on managing urinary incontinence, we're very excited about, because this is taking us into a system approach that really integrates primary care, specialty care, and community-based organizations in order to deliver patient-centered care in the context of multiple chronic conditions.
Reference link under the Advancing Heart Health Initiative, EvidenceNOW Tools for Change, https://www.ahrq.gov/evidencenow/index.html.
Next slide.
Title: EvidenceNOW Grantees, Heart Health, State Capacity, UAU, MUI. Graphic: a map of the United States with states labeled and highlighted in different colors and patterns to indicate which EvidenceNOW projected is involved with. States colored in blue are Washington, Idaho, New Mexico, Indiana, and Oklahoma. Blue indicates only heart health. States colored in blue stripes with a green background are Oregon, Colorado, North Carolina, and Virginia. Blue stripes on a green background indicate unhealthy alcohol use and heart health. Green indicates only unhealthy alcohol use. No states are colored green. Yellow with blue stripes indicates unhealthy alcohol use and incontinence. States colored yellow with blue stripes are Wisconsin and Illinois. Yellow indicates incontinence. States colored in yellow are California, Georgia, and South Carolina. Red and yellow stripes indicates incontinence and state capacity. States indicated in red and yellow stripes are Ohio and Alabama. Red indicates state capacity. Tennessee is colored red. Michigan is a green and red check pattern.
So you can see this slide just shows the geographic reach of all of these projects. Just so you can see that we've really covered a good, a wide geographic spectrum of the country. Next slide. So really our research, as AHRQ is a research agency, is a science of care. So we really want to know not only what works clinically in terms of treatment and management, but how do we make it work in practice? And we really want to move from a system that treats diseases and focuses on illness to one that treats people living with the disease in the context of their lives and focuses on wellness. And that's really important for urinary incontinence, as most people are coming in for many other problems, and it just gets left off the problem list. And that really that in order to implement effectively, we need partnership, research and co-production of evidence, both with frontline healthcare workers and clinicians, as well as communities and patients. And this really, you'll hear all of the new innovative methods that people are using in this project. But really multi-level interventions, agile implementations using mixed methods, addressing complexity science. So we're really excited about this project that's going to improve quality of life for women and at the same time advancing science on how do we improve care. Thank you.
All right, let's see. We'll take things back.
Title: The Challenge and Opportunity. Allison Wong, MD, MAS University of San Francisco. Lynn Kiley, UI patient, Northwestern Medicine Women's Integrated Pelvic Health Program.
So thank you so much, Arlene, for the great introductory remarks. And I should say, and I should have said it at the very beginning, in case you're wondering, who is this lady who's talking? So I'm Elizabeth Cope, and I am with the Academy Health team, and we are partnering with Rand, who is leading the Support and Evaluation Center for this effort in support of the broader Managing Urinary Incontinence initiative. And now we will be moving on and have a conversation with Dr. Allison Huang and Lynn Kiley, who are going to share some insights about the experience of both living with and also treating urinary incontinence from both the provider and patient perspective. And it's going to really help us have a more solid understanding of where the challenges are, but also where the opportunities are to have a big impact on quality of life and patient care. Dr. Huang is an internal medicine physician and has focused much of her research on genitourinary health conditions. Lynn Kiley, is an accomplished interior designer and a loving grandmother who has also long experienced UI symptoms, and despite having conversations with her doctors over a number of years, did not receive a referral or treatment until last year. So definitely have some opportunities for improvement to be talked about here, and I look forward to this discussion. So Lynn and Allison, from each of your perspectives, what do you think are the biggest barriers to successful diagnosis and management of urinary incontinence in women? And I think I'll turn to Lynn first.
Live video feed overlay speaker Lynn Kiley.
Right, I thought about this and I had lots of answers, and then I thought it comes down to actually a very basic first step, which is embarrassment. I think as a patient, most patients first suffer through the embarrassment and have no one to discuss it with. I've been on this journey for 25 years. And as Elizabeth mentioned, until my 39-year-old niece introduced me to urogynecology, I did not receive any treatment for 25 years, although I sought it. So anyway, I think that the first thing is the embarrassment of it and not sharing it with other people. There's a lack of communication between doctors and patients. There's a lack of communication to even share it with friends and family. So I think the overall lack of knowledge is the first barrier. Once you break through that and find out, I think that part of that is, creating a patient awareness and letting them know that there is access, to help, to treatments and procedures. A successful diagnosis can be followed closely, but it has to be developed. So some of the things I think, women can do on their own, and it can be encouraged through other things and everything that you were talking about. But you have to create the patient awareness first. And then, and that can be done through, talking, just simply talking, women to women, encouraging that, patient to patient, being in the waiting room, at Northwestern Urogynecology. I notice now that women always reach out. When I sit down, there's a woman there, there'll be 1, 2, 3, and they'll say, why are you here? What have you done so far? What treatments have you had? Have you had surgery? And they want to share, and they feel that that's a safe space to talk and learn. But there can be more. We can expand upon that. The doctor's time is so limited that doctors, and the primary care physician has all of these restraints. But as we mentioned in previous things, to have materials available, in the waiting room and in the examining rooms. One of the things is in breaking down this barrier, is to let patients know that they are not alone, that they're not alone because the numbers of the majority of women have some form of incontinence or will at some point in their lives, or they know many people that they're unaware of that are suffering from it every day. And that there are so many researchers and funders out there that every day new things are being created to solve the problems, but they don't know that the problems are being addressed. So I think that those are major things. Today, you see more and more advertising of products, but that's reactionary. Those are products in every store across the nation. Now I see them in magazines, full page ads for products. But again, that isn't being proactive. It's not finding a cure or a solution or even a treatment that can make life better. Not every treatment is going to be a cure, but it can totally improve a life experience and the quality of life. In the 25 years, my 25-year journey, which started with a bladder lift, 25 years ago, it was in 2021 that I was introduced to urogynecology, and then had a mesh sling lift and medications, and then an SM and M, the sacral neuromodulation that did not work for me, and then Botox injections. But there are so many options, and there are more every day, and all of you are working on this. And I know that there may be a few patients in the audience, but otherwise all of you are exposed to other people. I think being allowed to talk to each other and family members, and knowing that you're not alone, that the numbers are overwhelming, and being very proactive. I think that, I touched, and so did Elizabeth, about my journey, but my journey does not have to be everyone's. It can be far improved upon. And today I'm living a better quality life than I have for the last 20 years, for sure. Through the treatments that I have sought. But I'm in a major city with university hospitals, and not everyone has that. So I think that to reach out on a very basic level too, everything is being said about the primary care physician, but obstetricians and gynecology, that can all help too. And that every patient has to know, don't give up, because there are other treatments and options. But I think that if some of this can be expanded into in such a, we can't hit the broadest way first. So community centers and have guest speakers at various types of things on women's issues, and neighbor to neighbor. And as I said, speak woman to woman and patient to patient, and get the word out that, number one, they're not alone. There's no embarrassment, and there are solutions or treatments. So that's my story. But as I say, it doesn't have to be everyone else's.
Thanks, Lynn, for sharing what you've been through. First of all, it's just sort of upsetting, of course, that you had to go through so much to get the evaluation and treatment you needed. I think, as a primary care doctor, I probably don't think enough about how difficult it is for my patients to bring up issues like incontinence in the first place, and then persevere to make it through the system to get the specialized treatment they need. So I'm glad that it has worked out well for you in the end, but I'm sorry you had to go through so much to get there.
Okay, it wasn't that I didn't seek it. I'd never received a referral.
Live video feed overlay speaker Allison Wong.
So I think you're already bringing up like a good issues about like what are the reasons why like women who, even when they bring up these problems, are not getting referred or not being offered treatments that are going to work for them. So, I'm putting on my primary care doctor hat. I know that one of the biggest challenges for me is just all of the competing issues that I feel like I should be trying to address in my short medical visits. For my female patients, I feel like there's so many issues that I ought to be screening for, standard things like cholesterol, blood pressure problems, but also, depression and intimate partner violence and tobacco and substance use issues. And of course, depending on patient's age, screening for cancers like breast and cervical and colon cancer, all the vaccinations that women across the lifespan are supposed to get. And, I do struggle definitely to try and fit all of those priorities into these visits, along with the new issues that my patients are bringing up and management of chronic conditions we've already diagnosed at past visits. You brought up, Lynn, already the fact that medical visits have gotten so short. I think the senior physicians who trained me remember the time when new patient visits were an hour long or longer. And now the primary care visit is usually only 15 to 20 minutes long. And sometimes it feels like an impossibly short amount of time to tackle all the important things that my patients have. And then I think sadly, when time is short, I think healthcare providers default to what they know well and feel they can do quickly. And I think, unfortunately, for many primary care providers, that may not include thoughtful evaluation of the contributors to incontinence, or teaching patients how to practice first-line behavioral management for incontinence, or explaining the potential trade-offs of common medications for kinds of incontinence, or what kind of more specialized services would be available through referral. So, at the combination of things, all the important things that I think clinicians feel they need to address, the short amount of time they have to address it, and then the lack of confidence and our own embarrassment, right, about trying to tackle these things all come together and I think make it so much harder.
Definitely.
Then for you, I'm kind of curious, like the first times you brought up the symptom, did you feel like you were heard by your providers? Did you feel like they heard you but didn't know what to say? Did they offer you treatments, but they weren't ones that were going to help you? I'm just kind of curious.
No, they didn't offer any treatment or any referral. And they were internists at Northwestern in the same building where this whole other thing exists that I was unaware of. But no, physicians that I was very confident in, the answers were the exercises that we were told about, 25 years ago, Kegel. And it doesn't work. And it doesn't work for most people at all. And they'd say, have you tried, Kegel exercises, well, that's not a treatment. It's not a solution. It's not a referral. And 25 years later, to be asking for help and have it not referred to, no, I never came across anyone at all. And 3 different internists at Northwestern never made a recommendation. So that was it.
It sounds like, but you brought it up and your doctor sort of mentioned Kegel exercises, but then when Kegel exercises were not working for you, didn't go anywhere further with that. Or maybe there wasn't even a lot of discussion about Kegel exercises and in what situations they would help you or what situations they wouldn't help you.
Right. And it's probably age appropriate. And at my age, it wasn't going to work anyway. You know, I mean, there's a point in time that you've gone beyond that. So anyway.
Did you feel like, you know, you talked about how you felt embarrassed just to bring up the problem in the first place, so it probably took a while for you even to mention it. Did you feel like your healthcare providers had embarrassment also? Like, were they willing to talk about the problem with you?
No, they never discussed it further than my saying that I had the condition, you know, and was there anything that I could do? And they didn't have an answer to that, no. Since I started, you know, more recently in 2021 and understanding that more people have this, it's amazing to me that more people have actually approached me with their conditions. So I think that there is a little breakthrough that women are talking about it a little bit. You know, a very good friend said, oh, I have to go in for surgery. I said, oh my goodness, what, you know, oh, I have this condition, you know, and I finally found a specialist. And I live in the city, she lives in the suburbs, and we ended up in the same practice, you know, and she brought it up to me. That's sort of a major breakthrough. The only one I ever discussed it with was my sister, who has the same condition. You know, like you said, you thought initially all your patients had the same condition, but my sister and I did. But, you know, that was disappointing that I had never received a referral, but that's, you know, past. But the work that they do in the practice that I'm in is so reassuring. And I think that they have really taught me, you know, never give up. And that's why I say it to others. And the ladies in the waiting room will say, you know, did you do this? Yes. Did it work? And I'll say, well, it didn't work for me, but it may work for you. You know, everyone is different. Trying to be very optimistic with somebody that I don't even know, you know. And then they'll say, well, that's interesting because it didn't work for me either. And I want to change, you know. And I said, well, I changed to something else that I'm very happy with, you know. So it's supporting each other in a subject that isn't openly discussed at this point in time. So.
Live video feed speaker Jamie Alder.
Yeah.
I think that's a great point, Lynn, and I'll jump in. Hi, everyone. My name is Jamie Adler, and I am a senior manager at Academy Health. Elizabeth is having some technical issues. She's on, but not quite sure if she has speaking capabilities yet. So in terms of, this has been a fantastic conversation, Lynn and Allison, and we really appreciate you, sharing your perspectives, particularly with such a wide audience. In wrapping up here and moving on to the next pieces of our agenda as we begin to hear about what's being implemented, I'm curious if either of you have a quick takeaway as to what you would like to leave the audience with today.
Well, I would like to thank everyone for the research and the funding, and continue doing it. Don't give up. And then, with you, with your patients, I mean, there's always more. And so I just thank you all for your dedication to this subject.
For me, I'll just say, I realize in listening to what Lynn had to say that, because there are problems along every point in the pathway, right? There's problems with women feeling comfortable bringing up the issue in the first place. There's problems with, the clinician that they speak to responding appropriately when it first comes up. There's problems in the clinician providing appropriate education or information about first-line strategies like pelvic floor muscle exercises. And then there's problems in the follow-up if those strategies don't work, like getting the patient to the next stage of seeing a specialist or getting other kinds of second and third line treatments that may work better. So I guess I believe this with just a realization that it's a complex issue, right? There's no one single lesion in the care system that can explain every problem, and it takes more complicated solutions. So
it does. I have one other small suggestion that, I mentioned, having material in the waiting room and in the examining room, because there's always a little gap of time there that maybe someone could pick something up. But on each physician's website, there could be something. So if a patient goes on that and can recognize that they are sympathetic to urinary incontinence, that could also be something, part of the awareness thing. I think that this is available, that there are things available.
That's great. Absolutely, a good takeaway for folks to walk away with. And yes, Allison, complicated solutions, but it will take a village for sure that we will see this through. I would like to thank you so much, Allison and Lynn. We appreciate your time, and both will be on for question and answers later in the program. We're going to turn now to Jill Hubbard, who is at the Agency for Healthcare Research and Quality, AHRQ, to hear a little bit more about this Managing Urinary Incontinence initiative specifically. Jill.
Live video feed overlay speaker Jill Hubbard.
Good afternoon, everyone. Thank you for asking me to join. I can have the next slide.
Graphic illustration of the nomination assessment process as a reverse pyramid, with each step in the process in descending order, with a color gradient fading from deep purple to yellow, advancing in shades at each level. Each section is numbered with 1 at top and 7 at bottom. Sections are labeled as 1. Receive nominations. 2. Review against minimum criteria. 3. Assess evidence and impact. 4. Assess feasibility. 5. Explore implementation approaches. 6. Support investment. 7. Evaluate project.
So as part of AHRQ's dissemination and implementation process, we are charged with deciding what is the next thing to be funded. As you mentioned, funding is a big deal. There's lots of things that could be improved in the United States right now as far as medical care. So just a little history of why we chose urinary incontinence. We did a systematic review at AHRQ on the non-surgical treatments of urinary incontinence. That was sponsored by PCORI and was published in 2018. And there was good evidence for effective interventions. So we assessed that using our nomination process and decided that it was ripe for action. And then we had a stakeholder meeting to kind of figure out what is the right direction to go. Do we target patients, target providers? Is there more research, clinical research, bench research? What needs to be done? Next slide. And from that, we came up with a plan to address urinary incontinence. And these are some of the things that we found in our assessment. First of all, there's a huge public health burden. As you've already heard, many women have moderate to severe urinary incontinence. There are effective non-surgical interventions. There are patient-centered outcomes, that is, things that are important to the patient, such as her quality of life, her symptoms, especially social impact, and Lynn mentioned embarrassment, that really are hugely important to patients. There's an evidence practice gap with many women who are not screened in primary care. Those who have symptoms often don't seek care, and like Lynn described, many of those who have symptoms and ask for care don't end up getting appropriately treated. This fit really well with AHRQ's plan to improve primary care and to work with primary care practices through this EvidenceNOW type implementation. We thought we could work on both early identification and efficient use of specialty and community resources.
Reference statistics. Public health burden. 40% women report any UI. Approximately 30% older women report moderate severe UI. Evidence practice gap. Less than 40% screened in primary care, less than 50% with symptoms seek care, only 30 to 50% treated.
Next slide, please.
Illustration. Dr. Seuss's character The Cat in the Hat, wearing a bow tie and standing on a ball and balancing many objects.
So I'm a physician and I've been a provider, and to me, this is what primary care looks like. And usually the cat in the middle is not smiling. Providers are trying to juggle all the millions of things, including documentation, important screenings, as Dr. Huang mentioned. Patients may be trying to remember which is the most important thing for them today, or they may be distracted by lots of other little things, making it really hard to get to the bottom of what needs to be addressed at any one visit. So it's a bit of a jumble. Next slide, please.
Graphic funnel diagram with evaluation, grants, and resource center leading to improved treatment of UI for women in primary care.
But with this EvidenceNOW model, which Arlene described a bit, the plan is to use a combination of research grants as well as evaluation and a resource center to do two things, really. At one level, we want to make women get better care for UI in primary care. And the second thing is we want to evaluate to make sure that the practices are actually getting better. Next slide.
Title: Components of the MUI Initiative.
So we awarded this initiative as a U18 cooperative agreement with substantial AHRQ involvement. We have 5 grantees. Each of them gets $3 million for the project. And we have 1 contract, which goes to the RAND and Academy Health team. And they do a resource center, which is what's helping us host this webinar today, and an evaluation contract. They get 4 years because they're going to be evaluating even after the grantees are finished.
Grants have a maximum of 3 years.
Next slide. The purpose of the grantees, as I mentioned, is to make sure that non-surgical treatment for women is available in primary care practices, but also at the same time to learn which strategies work to improve primary care itself. And the contract, as I mentioned, has this resource center. They've done an environmental scan. They're providing technical assistance. They're helping to facilitate learning between the grantees. And they're also going to conduct a nice evaluation of the whole event so that we can assess what works, what doesn't work, what might be important to try to spread even farther than our current grantees. Next slide.
Title: Geographic Reach of MUI Initiative. A tan map of the United States. Grantee states are colored in yellow. Yellow states are California, Wisconsin, Illinois, Ohio, Alabama, Georgia, and South Carolina. Alabama, Georgia, and South Carolina are enclosed in a red circle with an arrow and the number 1 pointing to it. There are blue stars on the map indicating contracts. The blue stars are located in Washington, D.C. and California.
And this is the grantees of our MUI, Managing Urinary Incontinence Initiative, nice chunk in the Midwest, the American Southeast, and California. So we've got a nice demographic spread across the country. And our grantees are trying a bunch of different things. Next slide. So even though they're all charged with doing the same 2 things, they have unique features, and they're going to be telling you about those features. We have Wisconsin doing streamlined practice facilitation. Our pursuit team at the VA has a My Healthy Bladder mobile health app. The Northwestern team is using a shared decision-making product called Wiser Care. Our Empower team is using nurse navigation plus a chat bot. And the UC San Diego team is using a complex approach with 4 different arms so that we might be able to tell maybe which arm is better in improving care. Next slide. And through all of this, what we're really hoping is that we move primary care from looking less like the cat in the hat and more like Team Snoopy, and maybe even with the patients leading the way and getting the outcomes improved for the things that are most important to them. Next slide. Oh, that's it for me. I'm done. Thanks very much.
Title: Project Overviews. Empower, IT2, Pursuit, UCSD Wisconsin, Intuit.
Thank you, Jill. That was fantastic. Thanks for that overview. And a perfect segue into our next section here. Jill gave a little update and preview about who the grantees are that are associated with this initiative. So we're going to be hearing from all 5 grantees, starting with the Empower team, and we'll be hearing from Dr. Adonis Hijaz and Gautam Rao. So please.
Title: Empowering Women and Providers for Improved Care of Urinary Incontinence. Empower. Adonis Hijaz, MD. Lester Persky, Professor of Urology, CWRU Vice Chair of Academics and Research for the Urology Institute, Director, Center of Female Pelvic Medicine and Surgery, University Hospitals Cleveland Medical Center, Cleveland, Ohio. Gautam Rao, MD. Jack H. Medal, Professor in Charmaine, Family Medicine and Community Health, University Hospitals Cleveland Medical Center and Case Western Reserve University. Division Chief, Family Medicine, Rainbow Babies and Children's Hospital. Feed overlay speaker Adonis Hijaz.
Thank you.
Thank you, Jamie, and thank you everybody for attending this webinar. My name is Adonis Hijaz. I'm here together with Dr. Gautam Rao, who's my co-PI on this Empower grant. I'm the Vice Chair of Research and Academic at University Hospital, and Gautam Rao is the Chair of Family Medicine. Next slide, please.
Title: Project Team and Partners. A figure showing the project team members and their roles, with the university hospital's health system at top, splitting into one circle on left and one circle on right with a rectangle in the middle. The left circle says Primary Care Institute, the right circle says Population Health, and the middle rectangle says Principal Investigators. Adonis Hijaz MD Urology and Gautam Rao MD Family Medicine. Beneath it is another rectangle listing the leadership team. Adonis Hijaz MD, Pike, Gautam Rao MD, Pike, Ellen Divaki, Project Manager, Brig Conway, Evaluation Liaison, Sarah Koopman, Evaluation, Fred Schumacher, Evaluation, Mary Delansky, Dissemination, Rachel Pope, Implementation, David Shane, Implementation, Carla Harwell, Implementation, Esther Thatcher, Implementation, Kurt Stange, Consultant.
So this study, this project was conceptualized by a group of implementation and dissemination scientists within our university hospital health system. We were fortunate that Dr. Rao and I to have this team come together to put together the project. And it is indeed in collaboration with the University Hospital Population Health Division, as well as the University Hospital Primary Care Institute. So it's a team approach to hopefully tackle this problem that we have already identified and presented earlier. Next slide, please. Dr. Rao is going to talk about the project goals and take it from here, and then I'll step in back.
Live video feed overlay speaker Gautam Rao.
Thank you, Adonis, and thanks to everyone for joining this afternoon. So we have a basic goal of implementing our Empowerment for Improving UI program across a large primary care network, using strategies that are fairly established and some novel strategies as well. As Jill mentioned, nurse navigation, conversational agent or chatbot. But I think the most important of our strategies is patient empowerment, which means, and Jill showed you the cat in the hat, juggling different things. That's what I do at least 2 days a week as a department chair and as a practicing primary care physician, and it's not easy. So how does something that a patient prioritizes come to the surface? Well, often it is through a prompt or activating the patient to bring up their symptoms when they feel that's important, and that's a key part of our overall strategy. Second goal is to create an evidence-based care pathway based upon what we learn through the implementation of our intervention. And finally, of course, we want to assess the impact of the intervention on patient outcomes, not just urinary incontinence, but also in terms of satisfaction. And we want to know the impact upon practices as well. Next slide, please.
Map showing the University Hospital's consumer gateway service lines in Northeast Ohio, with color-coded location indicators for different care service types. Yellow indicates primary care. Red indicates emergency room. Teal indicates urgent care. Blue indicates convenient care. Black indicates orthopedic injury clinic. Purple indicates pediatrics. Orange indicates obstetrics and gynecology. White outlined in blue indicates lake health.
So the population of focus is quite large. So we are in the geographic region of Northeast Ohio. The population is approximately 3 million. We're targeting all adult women. This is a very diverse population because it's such a large area. So we have areas which are typically quite urban, economically challenged areas, inner city areas, as well as even rural areas, and of course, more wealthy suburban areas as well. The advantage I think that we have over other systems is that we are a large integrated primary care system within university hospitals. We have about 400 providers across nearly 100 practices overall. So quite a large system. I happen to have the privilege of being the academic leader within the Primary Care Institute, which includes all those practices. Next slide. And I think we're going to turn things back to Dr. Hijaz.
So I thank you, Gautam. The features that we believe are very particular to this project, and they include our understanding of the important patient-related barriers as well as practice-related barriers, and we took this into consideration when we conceptualized the study. And the second thing is, like Jill said, the cat in the hat, the picture, how the primary care physician is overburdened with multiple tasks. So our intervention was deliberately designed to minimize the burden on the physician. But the unique components for this intervention is conducting a large-scale screening and involving multi-layer intervention with providers, patients, as well as system empowerment within this integrated system. And one particular feature we talked about is patient empowerment through either direct interaction with the nurse navigator or through the artificial intelligence-driven chatbot called CC. So I think these are the components that we believe that are unique to our project, and I hope they will help us achieve our goal. Next slide, please. And what do you think, what would we believe the patient impact would be? We think the large-scale systematic screening will allow the patient open up about their incontinence issue. And then when patients screen positive, they are invited to participate in the implementation component. The second thing that patients will see is that they will be navigated through a nurse navigation and through the CC chatbot that will hopefully improve on their uptake, their adherence, their compliance to the treatment guidelines. The goal is to improve their satisfaction with the intervention, and at the heart of it is empowering them and educating them about the options for the management of the incontinence. Next slide, please. Gotham.
So I'm going to speak just briefly about provider impact. So we're not just empowering patients, we are empowering providers as well. So one of the challenges we face that with increased empowerment of patients, of course, more women will be diagnosed with urinary incontinence, more women will be requesting treatment, referral, whatever that happens to be, which of course places a great deal of pressure on primary care physicians. It's just like the phenomenon when as a primary care physician, if I go to a CME course on attention deficit disorder, I guarantee you in the months following my attendance there, my rates of diagnosis of that problem and management of that problem will increase. And that's exactly what's going to happen through patient empowerment in this case. So to solve that problem, we have put together an extension for community health outcomes video conference programs. So ECHO programs are all over the country for various issues. That is well underway right now. In addition to that, we're going to share our care pathways with both providers and office managers so they get ingrained into the culture of the practice. Each practice we have enrolled and will continue to enroll will include a champion who will be the point of contact for the research team within each practice as we move forward. And I think the most exciting thing, as Dr. Hijaj and I know, is that we are implementing EPIC at university hospitals. We're a little late to the game, but we are starting in the springtime. Actually, the primary care practices will actually be going through it. And that might seem like a very stressful time to roll out a new project or a new screening tool, et cetera. But actually, it turns out to be quite ideal because we have the opportunity to actually roll our screening tools into the electronic health record. So I think I need to stop here and see if there's any questions for either me or Dr. Hijaj.
Thanks to both of you. This was fantastic. And we really appreciate hearing about your project. I'm seeing some great questions come in through the chat and through the Q&A feature. We will have time at the end, I promise, to get to questions and answers. We'll go through all the presentations first, but please keep them coming. We love to see your questions coming in. And I know that we'll have a great conversation. At this point, we'll turn to the next grantee team, the IT2 team, and Dr. Kimberly Kenton will be presenting. Kimberly.
Title: Identify, Teach and Treat, IT2. Video overlay speaker Kimberly Kenton MD, MS, FACOG, FACS. Arthur Hale Curtis Professor of Obstetrics and Gynecology. Chief, Female Pelvic Medicine and Reconstructive Surgery Medical Director, Women's Integrated Pelvic Health Program, Northwestern Medicine, Northwestern University, Feinberg School of Medicine.
Good afternoon, everyone. Thank you guys so much for being here, and a special thanks to Lynn for being so open about some of the challenges that we have experienced at Northwestern and trying to get patients from the primary care office to get adequate treatment and even referrals to a subspecialty practice. So we really appreciate it. Next slide. So our project team basically is a partnership of our practice, which are urogynecologists, myself, Dr. Julia Guinness-Montanan, Dr. Sarah Collins, and we've partnered with the Primary Care Internal Medicine group. My co-PI is Dr. Stephen Purcell, who's a professor of medicine, and he actually directs the Center for Primary Care Innovation. And we couldn't do any of this work without our project manager, Tiffany Brown. And a really key partner in some of the work that we're doing is a company called Wiser Care, whose chief executive officer is a guy named Arul. He's also an internal medicine physician at UCSF, which has been super helpful. And Wiser Care is a company that we sort of stumbled across in our subspecialty practice, where they have like an advanced decision-making platform where they can use high quality medical evidence and data and combine that with patient preferences as well as some patient clinical data to help both guide the patient and their physician to come up with the best care plan or treatment plan for an individual woman. And we've leveraged that in our subspecialty practice, and now we're trying to take that and bring it to the primary care setting as well. Next slide. So basically our project goal is similar to Dr. Hijaz. We are in a big medical healthcare system that has many primary care sites. And so we really took the opportunity to leverage our multi-level like health system to implement primary care screening strategy at a system level. We hope to both identify urinary incontinence in the primary care setting. In addition, we are going to provide an opportunity to support patient-centered decision-making and education for urinary incontinence in the primary care setting, which we hope will then accelerate uptake of evidence-based non-surgical treatment modalities for urinary incontinence or appropriate referrals when necessary, which as we heard earlier today, humbly, in a very humbling way, we are not doing that at Northwestern. Next slide. So the population of focus is obviously all female patients presenting for primary care at Northwestern Medicine. Northwestern Medicine Healthcare Corporation is a large healthcare organization in Chicago and the surrounding suburbs that provides care to both a racially and ethnically diverse population of women. And in the past 2 years, our primary care clinics within the system have delivered care to nearly 300,000 unique adult women, which really we hope that we're going to be able to reach all 300,000 of those women with this study. Next slide. Our project features are basically, we are going to implement a system-wide screening that all women presenting for their annual wellness exam or any scheduled visit are going to get screened. They're going to get pushed some screening questions about urinary incontinence through the Northwestern patient portal. And if they don't complete these screening questions prior to the visit, we're going to implement workflows in each primary care practice that they'll be screened for the urinary incontinence when they hit the door of their primary care visit. Patients who screen positive for bothersome urinary incontinence, and I think that's really important, is we're really trying to capture women, not just that have incontinence, but they're bothered by it. And that they want more information will then automatically be given prior to seeing their primary care doctor an electronic invitation to complete the Wiser Care Shared Decision-Making module. And what this module is, we use it in our practice currently. It's basically a patient education module that talks a lot about the different types of incontinence, the different types of treatments. And then it also asks some kind of poignant questions for each individual patient to help them try to think through not only which type of incontinence they have, but which type of treatment they feel would work best for them. After the patient completes the Wiser Care module, both the patient and the physician are given a report that basically is a treatment preference map that helps rank all the different treatments that are available for urinary incontinence based on the patient's values, their treatment goals, and the risk-benefit trade-off that they've read. And this is a perfect way to start the conversation with the primary care physician. So the already busy primary care physician has an opportunity to start the conversation after the patient's already had some education. Next slide. So we feel that the impact for our patients and the women presenting for care at Northwestern, our urinary screening is going to be in primary care has become a standard of care throughout the healthcare system. It's going to happen at a system-wide level, and it should create no additional burden to the primary care physicians themselves. We think we're going to increase identification and counseling regarding the different treatment options to patients experiencing bothersome incontinence. And the patients who actually want additional information on urinary incontinence are going to automatically, before they see their doctor, are going to have access to a urinary incontinence education module that, again, is going to explain the different subtypes of incontinence, the treatment options, and really basic, clear language where we have illustrations before they even meet with their primary care doctor. And we believe this is going to improve both shared decision-making discussions with the primary care doctor, and it's going to make more focused, efficient counseling for the primary care doctor. Next slide. We think this is also going to benefit our primary care providers and physicians, and that their screening for urinary incontinence and patient education are going to be integrated into their workflows and the electronic health records. And much of this will actually occur prior to them even walking through the doors of Northwestern. Patients are going to have more background knowledge of urinary incontinence and treatment options, which is going to help the primary care providers help with decision-making discussions. And hopefully these discussions will be more impactful and efficient. And one of the things that we've learned in the gynecology data, many patients who even present for subspecialty care for urinary incontinence only want information. So I have to believe that if 40% of women that come to see me as a subspecialist really are just information seeking, there's probably a higher percentage of patients, women who have urinary incontinence that are in the primary care setting who are only in the data gathering phase. And this is going to make it really easy for them to get access to data without actually having long discussions with their PCP. We're also going to implement order sets to facilitate referrals to local resources. So the primary care physicians are just going to have to push a button, and they're going to have referrals to be able to go out to physical therapy. We're going to have a list of evidence-based medicines or subspecialty referrals to urogynecology as appropriate to save time for the clinicians. We hope that this is going to create a sustainable automated pathway that will become a standard protocol within the Northwestern medical healthcare system to both screen and treat primary urinary incontinence within primary care. Next slide. And I appreciate your time, and we look forward to further discussion later in the panel.
Improving primary care understanding of resources and screening for urinary incontinence to enhance treatment pursuit. Elaine Markland, MSc Professor and Director, Birmingham Atlanta GRECC University of Alabama at Birmingham, UAB, and the Birmingham VI Healthcare System. E. Camille Vaughn, MD, MS Associate Professor and Site Director, Birmingham Atlanta GRECC Emory University and the Atlanta VI Healthcare System.
Thank you so much, Dr. Kenton. And yes, I see some great discussions happening in the chat and the Q&A feature, so keep that going. We will turn to Drs. Elaine Markland and Camille Vaughn to present on behalf of the Pursuit team.
Thank you so much, Jamie. And I have the pleasure of co-presenting today with my friend and colleague, Camille Vaughn. We are both academically affiliated in two different settings, and also very involved in our VA work. And that's what I'd like to kind of share with you today. Next slide.
Project Team and Partners, MPI, School of Medicine logo. Elaine Markland, Camille Vaughn, Emory, Department of Veterans Affairs, Co-Is, Andrea Cherrington, Lisa Zubkoff, T. Mark Beasley, Beverly Williams, Katharina Echt, Staff: Kayla Reinecke, Emily M. Boyd, Hannah Burns, Carly Phillips. Partners: Ursula Kelly, Janice Phillips, Zach Birmingham, My Health Yvette, VI Women's Health Research Network.
We have such a wonderful team. Of course, any project like this is very dependent on having a team to help facilitate this. We are co-located in Alabama and in Georgia. We have expertise with our co-investigators ranging from prior AHRQ EvidenceNOW knowledge, dissemination and implementation scientists, biostatisticians, qualitative research expertise, nurse practitioners, program managers, program directors, community health leaders, and in community engagement expertise. And we could not do this at all without our partners. And with the VA system, we're very fortunate to have a VA Women's Health Research Network who's really supported us in our endeavors, both the work that led up to this current study and over the years, as well as bioinformatics expertise with the Salt Lake City VA. Next slide. So in brief, really, our main goal is to really help see how we can increase our primary care providers' knowledge of screening, diagnosis, and treatment options for incontinence, very specific for women veterans in the VA healthcare system. We then hope by increasing these providers' knowledge that we can actually impact patient symptom improvement. We have and currently testing a very novel mobile health application that really talks about pelvic floor education, pelvic floor muscle exercises, fluid management. It's very engaging. And then we also will be able to provide a telehealth consult with a continence specialist for women who desire additional treatment. And so with that, I'm going to turn it over to Dr. Vaughn.
Thanks so much. Yes, so we will be focused on a 3-state region in the Southeast. The VA network is divided into what are called Veterans Integrated Service Networks, or VISNs. And so our VISN is pictured here with Alabama, Georgia, and South Carolina. It involves around 65 or so primary care practice sites across that 3-state region. And we are hoping to recruit at least 50 of those to participate in the Pursuit project. We'll advance the slide.
Screenshot of a clinical data dashboard.
And so I'm going to tell you a little bit about some of our provider-focused features of the program, and then we'll hand it back over to Elaine for some of the patient-focused content. One thing that we know is even with all of our electronic resources, sometimes providers still want something that they can hold in their hands and just have right there at the, point of care or at their station where they're working. And so we've adapted some tools that were available through the VA and through our affiliation with the American Geriatric Society that are some content that the VA helped develop to give very brief summaries of management strategies. And then these are basically, while there's 2 pages there, that's a front back sheet that basically gives a very condensed overview of both identification, risk factors, management strategies for incontinence, and also is somewhat VA specific. So it offers the provider some information about products and treatment options available through the VA. The VA does offer continence products actually for veterans, and sometimes providers are actually not aware of some of the items that can be ordered for veterans. And then the other is a small pocket card on the side there that also lists some billing and coding information to help us with help the provider to identify, and that will also allow us in kind of a data extraction process to help look at rates of diagnosis across the project. And again, give some information about formulary options. Yeah, next slide, thank you. The next is just a brief de-identified screenshot of the dashboard that's been developed by our in collaboration with our colleague at the Salt Lake City VA. This is real-time updates every night with patient-specific information and is organized by provider. And so the provider can actually get a snapshot, or a member of their team even, to plan for the week, of women veterans that are assigned to their primary care clinic who have certain high risk kind of risk factors for the development of incontinence, and whether they actually have had a diagnosis code applied to their record for some of the most common urinary symptoms that are most bothersome for patients. And so this dashboard will also provide the team at the local clinic an idea of the next appointment for those veterans, and so that they can help work this into use this for their workflow to help with identifying patients who may not have been identified previously. As we know, it can be challenging both for patients and providers to bring up these symptoms sometimes in the busyness of a primary care visit. So we hope that this will help facilitate as well. And then, again, ultimately aiming to increase provider knowledge, we will be offering a CME session for the clinics as we roll out at each one, and ultimately help primary care providers feel empowered and with more resources just in time, kind of at the elbow in the clinic visit, to help overall improve quality of life for the women veteran patients that they're seeing. And I'll hand it back over to Elaine for the patient-focused items.
Thanks, Camille. Next slide, please. Our two-prong approach is definitely provider engagement, but we've also been very fortunate to be able to go direct to women veterans with recruitment for current studies. And I'm always surprised how many women haven't talked to their providers. And not surprisingly, we really believe that doing both is the right way to go. But we are recruiting directly to our veterans, and here's just some of our recruitment materials. But the slide on the picture on the right is actually a picture of our mobile health app, where we really do go into great knowledge. There's over 50 sessions. It's very patient engaged. We have patient stories that are very veteran centric. It talks a lot about what the VA in general has to offer in terms of incontinence evaluation and treatment. And so it's a daily session on a mobile app, and this is really just to get the ball rolling. This is a first step in treatment. Also includes detailed information on fluid management and pelvic floor muscle exercises. Next slide. And so, and this is our last slide. Our whole goal is really to take women veterans and give them the care where they are. This is about remote access. This is about getting access in their primary care clinics or directly at their home with a care consult if needed. We have the self-management tool, but we'll also have the ability to do video visits when necessary. I think that's it. Next and final slide. And we're done. Thank you so much.
Title: A practice-based intervention to improve care for a diverse population of women with urinary incontinence. Jennifer Anger, MD, Professor and Vice Chair of Research, UC San Diego Department of Urology. J.O. Kula, MD, MS Assistant Clinical Professor of Medicine, UC San Diego Divisions of Hospital Medicine and Biomedical Informatics.
Thanks to both of you. Fantastic. That was wonderful. We're going to turn now to Dr. Anger and Dr. Kula, who will be presenting on behalf of the UC San Diego team.
Live video feed overlay speaker Jennifer Anger.
Thank you so much. It's been so exciting to be part of this exciting endeavor, and getting to learn some of the different nuances that are being done at all the sites has been really helpful for us to start our work. So I am the PI, and Dr. Jijo Kula is our clinical coordinator, our site coordinator, and also is an internist, but also an informaticist. So I wanted him on just to show some of the clinical decision support tools that we've been doing electronically.
A graphic of a gray box with the leadership team, with arrows pointing to each of 4 circles. The farthest left circle is pink and contains the UCSD leadership and the University of California San Diego School of Medicine logo at the bottom. Arrows point from the pink circle to the logo for UC San Diego, ACTRIDISC, the word dissemination, and the logo for PCORI. There's a graphic of 3 circles in a row, with black arrows pointing to each circle from above. The circle on the far left is dark blue, with the logo for UCLA Health at the bottom. The text in the dark blue circle says UCLA Leadership, Janet Priegler, MD, Clinical Champion Team, David Rubin, MD, Primary Care Geriatrics, Neil Wenger, MD, MPH, Internal Med, Tamara Grisales, MD, Urigen, Informatics, Jennifer Singer, MD. To the right is a red circle with the Cedars-Sinai logo at the bottom. The text in the red circle says Cedars-Sinai Leadership, Carolyn Goldsweig, MD, Clinical Champion Team, Allison Mays, MD, Primary Care Geriatrics, Karen Eilber, MD, Urology, Victoria Scott, MD, Urology, Informatics, Joshua Pevnik, MD, MSHS. To the right is a light blue circle with the logo for Harbor UCLA Medical Center at the bottom. The text in the light blue circle says, Harbor UCLA Leadership, Catherine Ward, MD, Clinical Champion Team, Carmen Mendez, MD, Primary Care, Catherine Ward, MD, Primary Care, Taznuz Yazdani, MD, Urigen, Informatics, Rami Eskander, MD. Beneath the circles are arrows pointing to different logos. The dark blue circle is pointing to the logos for AHRQ and CTSI. The red circle is pointing to the logo for CTSI, the word dissemination, and the logo for Community Engagement and Research Program. The light blue circle is pointing to the logo for Community Engagement and Research Program and logo for National Association for Continence.
So this is our team. It's Cedars, 3 sites in Los Angeles, as well as UC San Diego. Of note, Harbor UCLA is a primarily sees an underserved population. So that's gives a unique Spanish-speaking patient population to help us identify any potential disparities in care. Next slide, please. Our main goal is to improve quality of care to primary care providers for the management of incontinence. And we will measure the care by doing chart review using quality of care indicators that we previously developed about a decade ago. And what we do is to do that, like, for example, did a doctor order a urinalysis? And then we can actually identify that kind of care in the medical record. Does improving primary care reduce specialty referral, or what we call unnecessary referral? Those patients, like Dr. Kenton mentioned, seeking information don't really need to be seen by, a fellowship trained specialist. Aim 3 is, can we actually improve? Does this intervention actually improve patient outcomes? Because that's really the most important. We're also looking at shared decision-making knowledge. We did develop a knowledge questionnaire to identify patient knowledge. And we also translated this and are validating it in Spanish as well as symptom severity and quality of life. And then as a secondary aim, are there disparities? And if so, can we reduce them through this intervention? So that's those are the main aims. Next slide, please. So this will involve Spanish and English speakers in primary care outpatient settings that have a wide range of insurance coverage, and again, focusing on Spanish-speaking Latinas. Next slide, please. So we will again apply quality indicators. This is a pragmatic approach. We randomize at the office level. So we will have control offices that really get standard of care, but we can measure those patients' outcomes, as well as intervention offices that will get academic detailing, which involves clinical champions. We also have added clinical decision support into the medical record, as well as the option to refer to an advanced practice provider to co-manage care. For example, our goal is not to give more to do to the primary care docs. That option didn't go over all that well with our primary care leadership. So if a doctor wants to give care for incontinence, but may not necessarily want to do it themselves, they can actually provide care through an APP who will do a video visit separately. And next slide, please.
Screenshot of best practice advisory application, quality and compliance.
And so Dr. Kula, will you want to take it away with the next couple of slides and just show what we've developed with the clinical decision support?
Live video feed overlay speaker Jeho Kula.
Yeah, thank you, Dr. Anger. One aspect that's important is, as Dr. Anger mentioned, we approach this as really a pragmatic clinical trial. So within the 4 sites, Although all 4 sites are implementing clinical decision support, each site is allowed to vary it slightly to accommodate the natural workflows of that site. So for example, at our site at UCSD, the workflow includes the electronic health record automatically identifies the subject who has been consented to participate in the study. When the subject is in the clinic, we notify their primary care provider that the subject stated that we're having bothersome urinary incontinence in 2 ways. First of all, the primary care provider's patient list for that day will show that this subject is participating in the Intuit study. The second thing is that using EPIC's notification mechanism, sometimes called a BPA, there will be a notification that the patient, who of course in this context is a subject, is experiencing urinary incontinence symptoms. And this particular alerting mechanism can work in one of 2 ways. One way is to allow for just very limited suggestions for orders, such as a urine analysis. For example, what we're showing here is the system that was customized for our UCLA hospital. We also, for the UCSD hospital, because we allow our CDS to vary a little bit, we designed what we call an order set, which is some clinical decision support about guideline recommended care. Could you forward to the next slide, please?
Screenshot of Smart Sets page.
So this particular order set allows us to do a few different things. It allows us to gather the appropriate documentation from the patient's history, physical, and the appropriate assessment and plan for a patient with new or worsening urinary incontinence. I see there was a great question earlier about, hey, do primary care doctors and doctors in general know to ask some probing questions towards your patients? And this is actually one of the things that we don't have a slide for this, but our documentation that we templated actually helps the primary care provider kind of jog their memory. You know, you need to ask more than one question because the documentation will actually hint the primary care provider to gather some of those tips that I think Bree here put in the chat, such as, hey, are you having to use pads? And if so, how many pads are you using in a day? Are you getting up in the middle of the night? Some other things that our clinical decision support does is guide appropriate medication therapy to try to ensure that medications are not used for the inappropriate type of urinary incontinence. Also, to make sure that medications that are used are appropriate for the patient's comorbidity, such as cognitive impairment and/or age. Finally, it also guides appropriate follow-up, including referrals for potential physical therapy for pelvic floor muscle exercises. So in summary, our order set here tries to guide guideline recommended care. And more importantly, the order set, once used and appropriate documentation is in place, it allows the system to no longer flag that particular patient as needing further care. So the next time that patient comes into the clinic, that same kind of alert system will not be bothering the primary care provider. Thank you, Dr. Inger.
Thank you. So the patient impact will be improved care, as well as improved knowledge. And just another element that we added, you know, we have electronic screening tools through DocuSign, but for example, for our underserved Latinas, who may not use email, we actually have a mechanism to screen by the phone. And so we're doing that. Next slide, please. They will get paid for their time. And then providers will get education. And so that's our goal of possibly changing care at the primary care level. Next slide. I think that's it. Thank you very much for your time. And again, for this exciting opportunity to be part of this group.
Awesome. Thank you so much for that presentation and for drilling down a little bit. I think that's a great conversation we've been having in the chat and in terms of screening, and look forward to revisiting that during the Q&A. So our last but not least, and so everyone knows, we went in alphabetical order here, so there were no playing favorites. We will have Dr. Heidi Brown present on behalf of the Wisconsin team. Heidi.
Title: Bridging Community-Based Continence Promotion and Primary Care, Wisconsin Intuit. Heidi Brown, MD, Moz, FACOG Associate Professor, University of Wisconsin School of Medicine and Public Health. Live video feed overlay speaker Heidi Brown.
Hi there, good afternoon. Thank you so much. I'm really excited to be here. You can go ahead to the next slide.
University of Wisconsin-Madison logo. Medical College of Wisconsin logo. Metastar logo. Photos of Heidi Brown, University of Wisconsin-Madison, Catherine Flynn, Medical College of Wisconsin, Joan Nooner, Medical College of Wisconsin, Mona Matthews, Metastar.
Our team includes myself as a urogynecologist, somebody who specializes in treating incontinence and other pelvic floor disorders, as well as an internal medicine doctor named Joan Neuner, who's a primary care doc with a special interest in women's health, and particularly older women's health, and a patient-reported outcomes measurement expert who sort of brings the how do we make sure that we ask the right questions and elevate the patient voice in the work we're doing. And those two PIs are at the Medical College of Wisconsin. And then finally, we have engaged Metastar, which has a 50-year history of doing practice improvement or practice facilitation and quality improvement with healthcare organizations throughout our state and neighboring states. So those are our sort of key partners in this work. Next slide, please. Our project goal is to ensure that primary care practices have the support and resources they need to manage incontinence in adult women patients without adding additional burden. And our team's research question is whether partnerships between primary care and community-based resources can improve rates of urinary incontinence screening and treatment. Next slide, please. So our population is a little bit different. We are squarely located in the Midwest, and we are recruiting practices across our state. We are not just recruiting practices from our academic health system or a particular health system. We are intentionally recruiting practices that serve rural communities and tribal communities, independent practices, as well as health system practices and academic practices. And we've enrolled practices that are family medicine, internal medicine, and OBGYN practices that provide primary care. And we're really trying to focus on the question of what works for diverse primary care practices in the real world, not just the organization that got the grant. How do we actually support primary care across America to include screening and treating urinary incontinence into their workflows? Next slide, please.
An example of the 3 steps.
Our project features streamlined practice facilitation. So we've learned from prior iterations of EvidenceNOW that traditional practice facilitation, which takes a lot of time, is more burdensome than primary care practices have the time for, especially even when it's heart health. So you can only imagine that urinary incontinence is going to there are going to be less hours and enthusiastic participants. So we're trying to do a streamlined version of practice facilitation that gives the benefits of tailoring without the intensive time commitment. And the way that we're doing that is through a menu-based approach. So most of what screening in medicine involves sort of 3 steps. Some sort of asking, or sometimes it's measurement of a blood pressure, and then making a diagnosis or advising, and then assisting patients with next steps for solutions. And so what we're doing with the various practices across the state is understanding what is their practice context and how do they ask, advise, and assist well for other conditions in their practice, and how can we give them a streamlined approach to do the same thing that they do with other conditions, the things that work well for them to do urinary incontinence. The other unique feature of our work is partnership building, with the idea that win-win connections can really make everyone's work easier. There are community-based organizations throughout our state that are delivering self-management workshops that build skills to do behavioral modifications to improve urinary incontinence. And those community-based organizations are pounding the pavement to recruit women to participate in their workshops. Meanwhile, primary care doctors are groaning when a patient asks about incontinence as they have their hand on the door to leave and go to the next patient. So we're hoping that through facilitating some partnerships, we can help both those busy community organizations fill their self-management programs and help the primary care providers. When the question gets asked, just as they're leaving the room, they say, yep, we've got a referral for you. So that's sort of the unique things I think about the work that we're doing. Next slide, please. The community-based program that I mentioned is called Mind Over Matter, Healthy Bowels, Healthy Bladder, and it's disseminated in our state by the Wisconsin Institute for Healthy Aging, which disseminates other evidence-based health promotion programs for older adults, like falls prevention or living well with chronic conditions.
A collection of messages from the Wisconsin Institute for Health Aging. Half of all women age 50 or older will experience incontinence at some point in their lives. Mind Over Matter can help you prevent or improve your symptoms. 3 sessions, 6 hours. Feel better and do more.
And this is a testimonial from a Mind Over Matter participant. In the last 3 months, I've only had 3 small leakages. Before the workshop, I used to have several leakages a week. I'm so glad I took this workshop because it has greatly improved my confidence. So we already have community organizations throughout our state offering this program, and there are actually 5 states other than Wisconsin that have folks licensed to disseminate this program. So it could be disseminated nationally and is being disseminated nationally. And it's also can be delivered virtually. So that's the potential impact for patients, is that there are things already existing that can be accessed even by folks who don't have subspecialists in their neck of the woods. Next slide, please.
A rotating 4-step infographic. Plan, do, study, act.
The impact for providers, I think number one, and it was actually Dr. Rao who said this at our first in-person meeting when we launched this program more than 6 months ago now, improving urinary incontinence improves patient satisfaction. And as doctors, a lot of times we're making tweaks to medications, and there's not a real, real concrete improvement in a patient's improvement when you change them from one blood pressure medication to another. But when you help a woman get drier, she is really happy, and that makes you feel good too. Embedded into our streamlined practice facilitation approach is Plan, Do, Study, Act cycles, which is a tried and true quality improvement program. Our quality improvement strategy. And so one of our selling points as we recruit practices is we're saying, this project is really focused on urinary incontinence, but we're hoping to give you tools that you can use to do PDSA cycles on whatever future topics you choose to do quality improvement in for your practice. And if you can do it with urinary incontinence, you could do it with anything. And then finally, we hope that the partnerships that we're facilitating will really support more than just urinary incontinence care, that the community organizations are offering other resources that can really offload primary care and can be mutually beneficial win-win partnerships. And next slide, please. That may be it. Okay, thank you so much.
Title, Q&A. Please put your questions in the Q&A feature.
Great. Thank you to all of our grantee speakers and to all of our speakers. I will have I welcome you all to come on to video at this point. We can take the slides down, headed into our Q&A, and we'll do some Zoom magic to make sure that you all are visible here to the audience. So I want to revisit some of the conversation that's been happening in the chat, and I think it was Dr. Kula who mentioned this, sort of starting at in the beginning of your projects here, where you are in terms of screening and sort of the patient encounter, and the nuances of asking patients about their UI symptoms. And so I'm wondering, and sort of putting this out to the group, if there's anyone who wants to come off mute and sort of speak about, what types of questions you're asking, and to Allison's point, in the very short amount of time that PCPs have in the room, how do you get that question across in a meaningful and resonating way with patients? So putting that out there for anyone.
I mean, I think we looked at just you're talking about when you're with the patient in the office, right? What do we ask? What do we want providers to ask?
Sure, or even in terms of how you're screening for your
Sure.
project. So it could go either
So the
way.
screening, because we have patients, I classically remember an 80-plus-year-old patient who's like, well, they told me I have incontinence, but I don't know why I'm here because it doesn't bother me, right? So our screening tool, and I want to hear what the others say, is do you have involuntary of leakage that is bothersome enough that you'd want to discuss it with your primary care doctor? And so that was where how we did our personal tool for screening.
Great, and I see that's resonating with Nancy in the chat. Curious to hear from others.
We're similar looking for bother.
I think I agree with both PIs. We are using the AHRQ, which is a questionnaire, which is validated questionnaire that capture incontinence, but also try to assess for bother as well as the type of incontinence. And if patients score on that questionnaire accordingly at the bother score, then we can we ask them to be involved in the study if they elect to do that. So yeah, we utilize the validated questionnaire.
Great. There's been some other conversation in the chat about pulling in other clinical professions, OT, PT, and curious to hear a little bit more. I know some of you touched on this during your presentations. Curious to hear a little bit more about incorporating those other professionals into treatment and what that looks like for your projects.
I'll just say our self-management educational mobile app program was very much developed with people in health literacy, health education, multiple different disciplines, behavioral expertise. So it really did involve PT, OT, not behavioral psychologists. And it was a wealth of information on the non-surgical treatments. So I will say that being a geriatrician, interprofessional, is the only way to go when it comes to what we try to do for our patients. It's just, it's not a one size fits all.
This is Adonis from the Empower team. We have engaged our PT colleagues also with us, and they are on our advisory board. But also, we expected that once we start the recruitment, that there will be an increase in the referrals for PT, whether it is because of the primary care physicians empowerment, which we can talk about it through the ECHO training or through the navigation and the CC chatbot. So we also, as the implementation team, we had meetings with our PT directorship and the PT team within our institution in preparation for the grant. And we actually encourage them to hire and train more people who are dedicated for pelvic floor within our system.
Great. Great. And so you talked a little bit about the demographics of patients that you'll be focusing on and reaching out to. Curious how you'll be involving the patient voice in your projects. I'm sure that might be of interest to folks on this call, particularly given the patient-provider discussion we had earlier.
Have patients on our advisory board, had them review and work with us in the development of the grant. Also, actually, initially when we developed quality of care indicators, and actually Kim Kenton was on my panel, we had patients there as well. So this was focus groups we conducted focus groups to get a better understanding of what was important to patients. And I think what's a little more challenging is we have Spanish speaking patients as well. So what we've decided to do is have separate advisory board meetings in Spanish, kind of subset meetings to make sure we incorporate like all of the diverse populations that we're seeing.
Yeah, I think that this is a significant problem. In other words, how do we engage patients and what's their role in these projects? And I think that as a primary care physician, I think that the greatest role they could play is in developing strategies for communication around the issue. So we have effective treatments. It's underdiagnosed. Primary care physicians are not as familiar with it as they should be. So let's develop strategies whereby patients themselves can be empowered to discuss this with their primary care physicians. And from that standpoint, there are subtleties of language. It's a sensitive issue, and it can be a culturally sensitive issue as well. So I think that's how our patients are going to be most valuable as we go through the project, not just in designing our interventions, but hey, we were not able to recruit a lot of patients in this particular demographic or this particular group. Maybe we're not going about it the right way. So informing that process is really important for us.
Great. Great. I see that we have a question that is focused on referring out from primary care to specialty like a PT, and that might present some access barriers or cost barriers to patients. And so curious sort of how that is integrated into your models for non-surgical treatment.
I don't know if I could take this question from on power side. The nurse navigator will, once they engage with patients, they take them through the care pathway. And these care pathways are well known to the specialist. And Jennifer and Kim, I mean, we practice this in our subspecialty every day, but they're not known to the primary care physicians. So we're taking these care pathways and providing them to the primary care physician through direct delivery of these care pathways, but also through education sessions. And the navigator in our proposal is in charge of helping the patients make the appointment with the primary care, but with the physical therapy department. And as I said, access might be an issue. We launched our recruitment of patients in September, and we have patients now that are going through the care pathway. We haven't reached a stage where we send them to physical therapy, but I think preparation ahead of time and alerting the physical therapist that if a patient is an empowered patient, that we want to make sure that they are able to access their services in a timely fashion.
Dr. Kenton, I saw you, and Heidi unmute. I don't know if either of you had responses.
Just that I think it really depends on your context. Like, I'm somebody who usually is seeing patients who've already tried pelvic floor muscle exercises on their own if they've gotten to my office, not always. But we have a lot of evidence-based tools to give patients information about behavior modifications that can improve symptoms. And if those self-managed behavior changes aren't effective, then working with an occupational therapist or a physiotherapist to implement those behavior changes, there is evidence that that is more effective. And partly that's the accountability, like having homework, having somebody that's going to know if you didn't do your exercises. Like we all know we're better when we have to report to someone than when we do it on our own. So I think that it is a continuum, and it's important not to say either that everybody should have unsupervised behavior modifications first. If you examine them and they can't contract their pelvic floor muscles, they should probably go right to someone to help. And if somebody's, not tried anything, then education is good. One of the other important things I think that we're doing, because I think a lot of the other projects are screening for incontinence outside of primary care, but we're actually having the primary care docs do that ask. And so they might not want to actually teach patients how to do a pelvic floor muscle exercise correctly. So making sure that there are resources like at their fingertips so that they don't need to do that teaching and take that time if they don't want to is part of our mission. which may result in people getting referred sooner.
I also think that there's a lot more to physical therapy than just doing a pelvic floor strengthening. I feel like many women who come in with urinary incontinence and lower urinary tract symptoms may have a weak pelvic floor. However, it's not weak because it needs to be Kegled. It's weak because it's actually too tight. And I think that, there's that balance of trying to figure out how to, in a screening program where you're not going to send women to trained physical therapists or, a physician that's actually trained to assess for pelvic floor muscle strength and high tone versus low tone. I think that not everything responds to a Kegel. And I think that there's, I think that there's some behavioral things and physical therapy things that we can encourage people to go home. But I really caution us to walk away from this counseling everyone. Here's a instruction sheet on how to do Kegels. I think that those of us that practice in the field see 20 patients every clinic who are like, oh yeah, my OB told me, 30 years ago to start doing Kegels. And then when you actually assess them, they're not doing them actually correctly. So just to kind of say that I do think that there's an important role for physical and occupational therapists in this treatment algorithm.
Thanks. I think that's a great point to end on, is that there is certainly nuance both on the patient and provider side to this type of non-surgical treatment. And so we're going to begin to close out here. So thank you all. These questions were fantastic. There are some answers. Some folks were responding in the Q&A, so please check back. If you answered a question, you might find a fantastic response and links in there. And so we hope that you also are able to visit the Managing Urinary Incontinence website. That will provide you more information about this project. And also after this recording, you will find all of the webinar materials online there. And if you have any specific questions or comments for this initiative, you can feel free to email us. The email is MUI_SEcenter@academyhealth.org. As we leave you here, we thank you for your time, especially on a Friday, and we hope that you are able to fill out an evaluation on this webinar. We take these very seriously so that we get some good feedback and understand what you all would like to hear in upcoming, in upcoming events. So that is being dropped in the chat right now. If you want to click on that and take a minute there to fill that out for us, we would appreciate it. Thank you so much to all of our speakers and presenters and everyone who put this fantastic webinar together. Thank you to the folks who stayed on to hear through the end through our question and answer. And we look forward to engaging you throughout this initiative over the next couple of years. Thank you.
For more information, please visit https://www.ahrq.gov/evidencenow/project/urinary/index.html or contact MUISE Center@academyhealth.org.
Thanks, everyone.
Thank you.
A big thank you to the SEC team.
Yes,
Yes,
thank you to
very-
AHRQ, SEC, RAND, Academy Health, Lynn. Thank you.
Oh, yes, thank
Thank you,
you.
everybody.
Thanks to everybody for being here. Appreciate it.
Right, great.
Bye.